Professor Andreas Hochhaus is the Director of the Department of Hematology and Medical Oncology, Coordinator of the University Tumor Center, and Co-Director of the Comprehensive Cancer Center, Central Germany at Jena University Hospital. He is full professor for internal medicine, hematology, and oncology at the Friedrich Schiller University in Jena. As co-chair of the German CML Alliance, Dr. Hochhaus is also focused on enhancing access to clinical trials for all patients and in driving patient participation in these. He has published 680 peer-reviewed papers and is co-editor-in-chief of Leukemia. As I mentioned, so Andreas has pre-recorded this presentation for us, and he will be discussing the key clinical highlights of EHA.
Dear colleagues, hello. I would like to summarize the highlights of the European Hematology Association meeting 2025 in Milan with regard to chronic myeloid leukemia clinical presentations. These are my disclosures. Jane Apperley summarized the results of the 2025 ELN recommendation panel for the management of CML. This is actually the fifth version of the ELN recommendations after 2006, 2009, 2013, and 2020. The process for the development of ELN recommendations have been established in detail. There are now 38 panel members from Europe, North America, Asia, and Australia. We reviewed the previous version, in this case 2020, and identified areas in which new data and improved evidence is available. Jane developed a series of questions concerning definitions, management decisions, etc., and it was required to achieve a 75% consensus. If this was not achieved, a further round of questions was distributed. There were in-person and virtual meetings, and when the consensus was lacking, the controversial issues are discussed in the text. I don't want to go into the details of the recommendations because they have been published meanwhile in Leukemia and are available open access. There is a list of chapters in the recommendations from diagnosis to adverse events, which are covered, but consider mainly the new data between 2020 and 2025. The recommendations have the aim to be applicable worldwide to expert and non-expert CML physicians. And with the recommendations, we want to prevent or delay progression and want to improve the overall survival of the CML patients worldwide. But apart from this, we want to identify patients who are suitable for treatment-free remission, and we want to improve the rate of patients eligible for TFR and the rate of patients being stable after discontinuation of the drug. And with that, of course, we want to improve the overall quality of life of our patients. WHO has published in 2022 new criteria for the definition of the disease phases in CML. More than 20% blasts are now considered a blast phase in bone marrow or in the peripheral blood, and CML has been redefined as a biphasic disease, and this is still controversial whether or not we should omit accelerated phase at diagnosis and during therapy. At diagnosis, the risk factors which defined accelerated phase were very heterogeneous and therefore not very straightforward. Therefore, they are now considered as risk factors in chronic phase and not a specific accelerated phase at the diagnosis. Genetic studies suggest that CML is a biphasic disease. There are arguments against this change because the dismissal of a long-standing and well-understood definition may lead to confusion when we compare data with older studies. For prognosis, at diagnosis, the high ELTS score has been established as a specific risk factor, and the ELTS score is recommended to be used over SOCAL or the Euroscore, and cytogenetic analysis with additional chromosomal aberrations at diagnosis is important, since the high-risk aberrations like 3q26 and others are important for the outcome and maybe trigger for early allogeneic stem cell transplantation. Less clear is the role of the transcript type E13A2 versus E14A2, and somatic mutations in genes other than BCR-ABL. There is increasing evidence that at least the A6L1 mutation may have an impact on the achievement of MMR during therapy, but is not standard to use next generation sequencing at diagnosis to find these mutations. However, several groups found that the chance to achieve major molecular response, the risk of failure-free survival, and the acquisition of kinase domain mutations depend on the mutation of A6L1 at diagnosis. Therefore, we need more data to demonstrate this effect in more patients and to tailor therapy accordingly. The milestone table, the numbers of the milestone table has not been changed very much. There are very similar numbers which you already know from the previous tables, but the wording has changed, the headers have changed. We have now a favorable category and an unfavorable category. It's not called failure anymore, because some colleagues expressed the opinion that patients may continue therapy in individual situations even after failure to achieve these milestones. No TKI switch should occur on the basis of a single result. We need a confirmation of these results, and we see in the failure category also some patients who are late responders. We need to change treatment to optimize the achievement of treatment-free remission with the aim to achieve deep molecular response in these patients. Asciminib was included in the recommendations, registered worldwide for third-line use, but now in more and more countries after the initial FDA registration for first-line use as well. And this is based on the ASC4START data, Asciminib versus all available investigator-selected TKIs, Asciminib versus imatinib, and Asciminib versus second-generation tyrosine kinase inhibitors. There's no p-value here with the second-generation drugs because the study was not powered for this comparison, but MMR rates are advantageous in all these categories, independent of the comparator. The Asciminib is better tolerated than all the comparators. The adverse events leading to discontinuation were only 5% in ASC4START compared to 13% with imatinib and also 13% with the second-generation drugs. And this is the case also for adverse events leading to dose adjustment and dose interruptions. The choice of the first-line treatment should be based on a shared decision-making between the doctor and the patient, and we need to consider the aim of the therapy, the overall survival. Is it overall survival or is it treatment-free remission? We need to consider prognostic factors at diagnosis. In case of high-risk ELTS, a more active drug should be chosen. And of course, we need to consider the comorbidities and the specific side effect profile of the selected drug. And when we consider the worldwide applicability of these recommendations, the affordability and availability of these specific drugs. A little has changed for the definitions of the eligibility for treatment-free remission, but the frequency of monitoring has been reduced in the recommendations, of course, depending on the individual PCR levels. But MMR, loss of MMR, remains the trigger for restarting the therapy, and it does not require confirmation for safety. The risk of recurrence directly into blast phase is estimated at less than 0.1%. And now in patients with atypical transcripts, TFR approaches are also permitted, but they require a high standard of quantification in a specialized lab. I had the pleasure to present the interim analysis of the ASC4START trial comparing Asciminib with nilotinib first line. The randomized comparison was 1-to-1 and stratified by the ELTS risk category at the time of diagnosis. There was a pre-planned interim analysis which was now done at 50 events. This was considered in the statistical approach in this study. The primary endpoint was very special. It was called time to treatment discontinuation due to adverse events, or TTDAE, to meet the requirement by several agencies to show that Asciminib is better tolerated than other drug for first-line registration. But the typical efficacy endpoints, MMR and others, were included into the protocol as well. The interim analysis shows a significant advantage of Asciminib over nilotinib for the TTDAE endpoint. That means more adverse events led to discontinuation with nilotinib, 34 out of 282 patients, than with Asciminib, 16 out of 284 patients. The adverse events which led to discontinuation with nilotinib were mainly pancreatic and liver toxicity, with Asciminib transient cytopenias in the early phase of the treatment, which are combined with a higher efficacy of the drug. The efficacy endpoints are listed here. BCR-ABL less than 10%, less than 1%, MMR, and even deep molecular response at 12 weeks or by 12 weeks show an advantage of Asciminib over nilotinib. In another presentation, Jiří Mayer presented interim analysis of the phase 2 study, half of the CEL, the Czech leukemia study group for life. This study is based on the assumption that dose reduction prior to discontinuation may reduce the withdrawal syndrome. And the protocol here shows that there were 2 steps of halving the dose. That means prior to discontinuation, patients only take a quarter of the initial dose of the drug. And the study enrolled between 2020 and 2023. 207 patients were enrolled. The median age of 62 years. First-line treatment was in most cases imatinib, but also nilotinib, and in a few patients dasatinib or bosutinib. This graph shows the results, the probability of TFR. In the de-escalation phases, there were already some relapses, but the overall probability of TFR is around 60% now after 36 months after the first halving phase. The authors conclude that with these 2 halving steps, the withdrawal syndrome can be reduced significantly, and patients can be identified who have not such a stable situation to go into TFR and they get the full dose of therapy again in case of the relapse earlier during therapy. Concerns about this approach are that the dose of the drug may be too low to suppress all the clones, and mutations may come up, but this should be shown in the final analysis of the study. I presented for the first time the ENABLE data. This is a phase 1A, 1B study with ENLIVEN-01, a new selective active site inhibitor of BCR-ABL in patients with previously treated CML. The advantage of this drug is the specificity. It does not inhibit KIT, FLT3, PDGF receptor, VEGF receptor, and SRC. It also binds the P-loop, but it can be taken with or without food, and it's not an inhibitor or substrate of most of the cytochromes. Therefore, the co-administration of other drugs is not a problem like with other ATP competitors. ENLIVEN-01 suppresses clones with mutations, with BCR-ABL mutations, which are resistant to Asciminib, shown in this table. Based on these preclinical advantages, ENLIVEN-01 was tested in a phase 1 study, starting with 10 milligrams once daily to 80 milligram BID. And 80 patients are planned in this dose escalation phase. And after that, there's a dose expansion phase with 60 versus 120 once daily, and with a specific cohort for patients with 315 mutations. I had the pleasure to report now 90 patients with a median age of 58 years. Most of them had typical transcripts, but also patients with atypical BCR-ABL transcripts were eligible for these studies. 26% of the patients had 5 or more prior lines of therapy, including Asciminib and ponatinib. The overall MMR rate by 24 weeks is now 47%. Considering the heavy pretreatment of these patients, that's quite good. And 32% post Asciminib and 35% MMR post ponatinib. I think these are very good efficacy data, but also the tolerability of the drug is good. There is no MTD currently, with a few DLTs in the individual cohorts, but no MTD overall. There's another new drug which is called TERN-701. Tim Hughes presented the preclinical data of the development of this drug. It's another allosteric inhibitor like Asciminib, but it has some advantages in the preclinical assessment over Asciminib. It inhibits with a better efficacy some of the Asciminib with the mutations resistant to Asciminib, like 244 and 359. And it shows a higher specificity for ABL, shown in this graph here, compared to dasatinib, which is a multi-kinase BCR-ABL inhibitor. And it inhibits with a higher efficacy in preclinical settings most of the tested tyrosine kinase mutations. A phase 1 study is ongoing. It started with 160 milligram. It could start with such a high dose because a second phase 1 study was conducted in China, and the FDA permitted the use of a reasonable dose of TERN-701 in this study. There is the planned approach between 160 milligram and 500 milligram in the dose escalation phase, and then a dose expansion phase with 320 versus 500 milligram. Tim did not report on the results of this phase 1 study. He reported the preclinical data only. There were other presentations in the CML sessions, like a presentation to optimize tolerability of dasatinib from India, a randomized trial comparing 70 versus 100 milligram dasatinib, which showed equal efficacy, but better tolerability of dasatinib. That means another study which demonstrated lower doses of dasatinib may be efficacious and better tolerated. With that, I would like to close my presentations, and I'm of course available for your questions. Thank you very much for your attention.
We are now open for your questions. Giora.
Hi, good to see you all. Thank you. Well, I have a question for my doctor. Andreas, you talked about the efficacy and tolerability of Asciminib, and you presented the data, but we also heard data about mutation that are emerging in the myristoyl pocket. Can you comment on that, and how worried should we be about those mutations?
So Giora, apologies if I hadn't made it clear. So Andreas is actually not able to join in person, but I will put your question to him via email. But in the meantime, so we have several of the ICML advisors actually on the webinar, but Professor Tim Hughes is here. Tim, would you like to answer Giora's question?
Yeah, it's a important question, Giora. Thanks for raising it. There certainly are myristoyl site mutations emerging on Asciminib. So in the ASC4START study, around 5% developed mutations, and they were all myristoyl or myristoyl site mutations. It was 4% with imatinib, it was about 3% with the second generation. So it's not massively different. But what is massively different is the very tight association between having ASXL1 at diagnosis and developing these mutations. So whereas with imatinib and to some extent with the second generation drugs, patients with and without ASXL1 can develop mutations, it's almost an exclusive relationship, which is really fascinating, and we're trying to understand why that would be. But I guess it's an opportunity actually to focus our attention on those patients and to try and find a better strategy. So the positive side is that we know the patients we need to worry about. It's the ASXL1 patients. There were very, very few mutations in patients with either other cancer gene mutations or no mutations. So I think overall it's a pretty reassuring story.
Okay.
Thank you, Tim. Any other comments or questions? I can't see anything in the chat.
Ooh. I have one, Nicola. Hi.
Hi, Katia.
I have one for Tim, if he can ask. It's about the new drugs LV1 and TERN-N. Can you give a hint about which scenario would we be using these new drugs for CML treatment? Which one and which occasion? I know the data are very preliminary, but if you could give some hints, how would you use them? Thank you.
You're referring to TERN-701, Katia?
TERN and LV1, ELVN. Which one would you use when? One of them. Okay.
I guess I'm more familiar with the TERN data at the moment. And it looks very promising. I mean, will it have any advantages over Asciminib? It's hard to say at the moment. I mean, you saw the evidence that it may be better against some of those mutations that are a problem. In our study in Australia, we had 2 patients out of 100 who developed the 244 mutation and 1 who developed a 315. And it's quite possible that the TERN drug will have a better profile, and maybe they won't be such a problem for TERNs. But I think other subtle differences in terms of toxicity profile will emerge with time, I think. I think the data is very promising. For the Enliven, I think it looks very impressive. I mean, I've seen the data as much as you've seen the data. It looks to be pretty high rates of response in patients who've received a lot of other drugs. And it's not hitting the other kinases that we worry about, PDGF, KIT, SARC. I think that's good news. I don't know what it does hit. We don't really have a complete profile on what it does hit, but I think they're both pretty exciting drugs that are going to find a place in the next 10 years, and I guess the phase 2 studies are going to determine how big a place they occupy.
Thank you.
I have a question to Tim also.
Hi, Joel.
Hi, Tim. How are you?
Good.
Going back to the AX7 mutation and Asciminib, and with those data, would you ask for an NGS profile to do when you start Asciminib for those patients?
Yeah, I mean, this is an area of controversy. It was something that was discussed by the ELN committee. We were asked that question, should we be doing NGS as a routine now? And the answer at the moment is no, because even though we are recognizing the strong association between ASX01 and treatment failure, particularly driven by kinase domain, well, by ABL mutations, we don't yet know how to overcome that. So at the moment, we're doing a trial in Australia where we're using combination therapy for those patients with ASX01. Maybe we'll show that's a good approach. And if that's the case, then it becomes justifiable to do NGS at diagnosis. But at the moment, it's hard to justify. It's expensive. Yes. If you don't know what to do about it, then it's hard to argue that it's an essential test. But I suspect that we will develop strategies to reduce the risk of mutations in those patients, and then it'll become part of routine diagnostic assessment.
Thank you.
Thank you.
Hi, I would like to ask, thank you, a question for Thomas. And it's related to the predicted role of cytokines in patients who discontinue. Do you think, or you have seen in EHA any work about the importance of the cytokines as a predictor?
Thank you very much, Carolina, for this question. So this is like an ongoing and I would say two major suspects. Immune system is taking control, and this is the reason why patients can continue TFR, or maybe there is kind of like a background genetic predisposition, or maybe there is this famous unknown player, so we don't know what is it. So in favor of immune system, I can't see Bob here, so Bob will immediately criticize immune system. Bob Gale, you know, he's not a fan of immune system. But anyway, the last presentation, which I only gave a title, the data mining in Euroski by Dr. Rinaldetti, he showed that plasmacytoid dendritic cells are enriched in this TFR continuing patients. Plasmacytoid dendritic cells are the major antigen presenting cells. Also NK cells are enriched. So I was teaching immunology for more than 20 years, so I'm a fan of immune system, but I'm not really convinced that immune system is the major factor in taking control. But I think in at least some patients, immune system may be responsible. But specifically, if you ask those specific cytokines, I would avoid this approach, because, you know, you cannot look at the immune system in a perspective of like, you know, interleukin 18 or interleukin 12. You know, this is kind of like a huge cocktail, and you should look rather at the specific immune cell population. So this is still a question on the table, and you will find many fans of immune system, but also some also will be contrary to this.
Thanks.
Giora?
Yeah, can I ask another question, Thomas, please? Thank you, Thomas, for the presentation. And I have a question. As a patient, I've been hearing for many, many years about different prognostic and factors that can affect the success of TFR or success of TKI treatment. In your prediction, how close are we to really implement it in real life? That a patient will come to the diagnosis, be checked, and then you'll be told you have to be treated by this TKI, you have better chances, or your chances of stopping treatment are now higher than the average of the 50% to 60%.
So I'll start, of course, with a joke. Just you can ask ChatGPT Pro version, and you will definitely get an answer. But now, seriously, what was presented by in this first talk, I'm sorry I missed the name of the presenter, but the presenter was from the Nordic study group, Dr. Gulaksen. So he presented, this data about the analysis of, let's say, proteome and also the phosphorylation profile right after the treatment starts. So like 3 hours after the first dose of nilotinib and dasatinib. Of course, they have this mass cytometry, which, as I mentioned, is not like a typical equipment. But this is one very nice approach because actually this is not a very expensive test once you will get this machine. Okay, and as any type of cytometry, it's rapid. You just need a blood. So I think the future is here because I'm a little bit skeptical about single cell sequencing, IVR transcriptome. This will be probably only in big centers. So if you ask me to play kind of like a prophet tech crystal ball, so I think in 5 years. I think we still need a couple of years.
Okay.
It's not a matter of next year. It's a matter of few years. But I think it's achievable. I hope that CML will still be the forefront runner in this huge field.
Thank you.
Thank you, Joe. Thank you, Joe.
This is Charlie Schiffer. If I can add a little to that question.
Hi, Charles. Good to see you.
Let's not forget how good the therapy is. That is, you have a survival just going from one TKI to another that approximates age-adjusted survival in the normal population. That makes it a heck of a lot more difficult and frankly less important to identify which TKI might be best at the time of treatment. With respect to TFR, it might be nice if you could show that starting with one TKI will get you higher rates of TFR. But the reality is at the moment, 50 to 60%, I'm sorry, turn it over and be optimistic. At least 30 to 40% of people will relapse no matter what TKI you use. And frankly, that's the biology that I think interests me the most. But let's not forget how well we do just bouncing from one now increasingly inexpensive therapy to another. And also remember, I think that a significant fraction of the failures are people who have bad biology and are presenting with more advanced disease at the time of diagnosis.
This is definitely true, especially with respect to the CML stem cell compartment. What I started, the Dr. Rick Van Etten, presentation that the CML stem cell compartment at the diagnosis is one of the most important factors for the successful treatment.
Thank you both. Dr. Malhotra from India, one final comment and then we'll wrap the session up.
So hello everybody, wonderful talks, thank you. My question is to Tim. Tim, do we have data on the myristoyl inhibitors, particularly Asciminib, in the pediatric population and in the pregnant patients? Are there any recommendations out, or is it too new to have data for that?
With regard to the pregnant patients, it's way too new. I think we now have some fairly reassuring data about imatinib and nilotinib, not dasatinib, particularly in the sort of third trimester. I've never done it, but it has been done, and it looks relatively safe. So I think that apparently can be done. In terms of pediatric use, Asciminib, I see that Dr. Milo is on the line. Perhaps he could comment. I don't think we've gone very far at this stage. I think there are some trials just starting, but do you have any comment on that, Dr. Milo?
Do you hear me? Do you hear me?
Yep.
Okay. Sorry for the technical aspect. In fact, there is an ongoing trial regarding Asciminib, international trial, and the patients are currently recruited for the assessment of the response and the toxicity of this drug. But it seems, I heard, I was not in Milan, but I heard that there is interesting things regarding impact of Asciminib on growth in pediatric population, because we know that the main problem, one of the main problem in children is the impact of TKI on growth, and maybe this information will be very interesting, as well as regarding bosutinib, regarding this aspect of specific aspect of toxicity in children and adolescents.
Thank you. Thank you very much.
Okay. With that, I can see definitely lots more to discuss. Thank you. Please join me in thanking our presenters for today, both Professor Hochhaus, who was unable to join us but kindly recorded his presentation, and Professor Stockloser and Professor Hughes for kindly jumping in and answering questions. Our next highlights will be of the John Goldman meeting. If you cannot join us in person in October, which we hope to see you there, but there will be highlights of that meeting and a webinar in late October. So again, thank you for joining us, and thank you again to our presenters.